on the topic of acceptability, wider acceptability and use of CGM devices in general, but especially for diabetes management from an Indian perspective. With that note, I think now I'll ask the...
Welcome to NUCD, National Update on Clinical Diabetes. And with this session, this technology and diabetes, we have none other than Dr. Banshi Saboo, the tallest figure in the field of diabetes and technology, with whom I'll be discussing the different aspects of CGM and how the common people will be able to use it. Welcome, Dr. Saboo, to this meeting.
Thank you.
So, for the viewers, our doctors, would you like to say something shortly about CGMS and how do they change the lives?
So first of all, Dr. Alok, I am very much thankful and grateful to you for giving me this opportunity. And as I am a regular faculty of your NUCD since last 10 years, being it physical or being it face-to-face or on virtual mode, I am really thanking you for giving me an opportunity to talk to you about the continuous glucose monitoring, as it's a very important topic. In last 5 to 7 years, the complete paradigm is shifted as far as monitoring is concerned and the diabetes management as per the monitoring. Now, few things before I talk about the CGM, which one should know that the monitoring in our country is really very, very poor. And I'm sure you will also agree with this, that many of our patients, they continue to take the medication, but they don't monitor it. So that's number one point. And that I personally feel that's one of the very important reasons that 2/3 of our diabetic patients are not under good control. Now, the second big problem is the hypoglycemia is always a limiting factor for a tight glycemic control. So just giving a simple example, suppose our patient is having HbA1c of around 8 or 7.5 or 8.5. It becomes extremely difficult for our doctors to intensively now achieve this 7.5 to 8.5 to below 7 or 6.5 because they are worrying of hypoglycemia, and definitely the number of episodes of hypoglycemia will definitely increase when you are trying to achieve a control which is around 8 or 8.5 when we want to take it less than 7 or 6.5. Now, I am lucky that I am the part of International Consensus of Continuous Glucose Monitoring in 2017. Rather, I was only one from Asia who was part of these global experts, more than 40 experts from all over the world. And we decided that who should be on a continuous glucose monitoring. So not all type 2 diabetic patients. As you know that Dr. Alok, it's not possible that all type 2 diabetic patients, but definitely all insulin taking patients, all type 1 diabetic patients, if they can afford and if they have access, they should be given a continuous glucose monitoring. Then after 2 years, in 2019, again, I was the part of that expert consensus, which has been published in Diabetes Care. And we all started talking about time in range. Again, I was part of it. And we have come out that those people who are using continuous glucose monitoring, more than 70% of the time, they should be in time in range. So I mean, out of 24 hours, in 70% of the time, most of the time, their sugar should be between 70 to 180, and that is what we call its time in range. So these two important landmark papers which were published, and I was lucky that I was part of these two expert consensus group in 17 and 19, and which is accepted by all over the world across all the bodies, now accepting that it is not only the A1C which is sufficient for our patient, they should do a time in range, a new way of monitoring glucose in our patient. So I mean, using continuous glucose monitoring will give you a 24 hours glycemic pattern, a glycemic profile, and in that you try to find out that how much time a person is remaining in time in range. If it is more than 70% of the time, it means you are doing reasonably well if there is no hypoglycemia. If it is not, then you change the therapy in such a way that less and less hypoglycemia or negligible hypoglycemia with increasing time in range. That is our concept of treating patients with diabetes. Now, question always come when we are talking about continuous glucose monitoring and time in range. Everyone will accept that, yes, if you're type 1 diabetes, your geriatric patient, your insulin taking patient, your patient who is ill or who is using insulin, if they can afford, they can put on CGM. But what about routine garden variety of type 2 diabetic patient, whether they should use CGM or not? That's an important question. So last year, me, Dr. Alok Mishra, Dr. Jyoti there, we had come out with a one paper which that how frequently the people with type 2 diabetic patient should also do the continuous glucose monitoring. In India, since last 6-7 years, we are using flash glucose, which is a cheaper alternative. It's not like a CGM. You can flash it and you can get it, and it's pro. And that gives that paper in which we talk that those patients who are not controlled, it can be repeated once in 2 months to 3 months. But those who are relatively well controlled, it can be done even once in a year also. So it's not necessarily that your all type 2 diabetic patient should be on continuous glucose.
So you mean to say all type 1 diabetes patient should be on CGM
if they can afford.
If they can afford, and some selected type 2 patients can also be in CGMS if they are not able to control their glucose level.
But if they are on insulin and if they are geriatric, if they are at higher risk of hypoglycemia, if they are hypoglycemic, unaware, they have multiple comorbid condition, they should be given a choice of CGM continuously. But the condition in India, if they can afford.
As you know, the doctors know that there are few types of CGMS. Would you like to say something on that? The
Yes.
3 types of CGMS?
Yeah, so there are 2 varieties. One is a professional one and one is a real time. So professional one means you will get the data retrospective. A pro, it is iPro or it is what we call it's like one is Medtronic also have a pro, which is, and the second one with the Abbott, which is Libre Pro, which we commonly use. What happens? The monitor is with the doctor's clinic. Patient is put on a chip, which is a sensor. Patient had to come to the clinic again, and professional one, they give the report of last 4 days, 5 days, 7 days, 14 days, whichever number of days patient was put, and that data is come out. This is known as professional. The other is a real time. It means the person has not to come to the clinic or retrospective data. They can do it continuously and they can see. Now again, in a real time, there are 2 varieties. One is a flash glucose monitoring and other is real time. Flash glucose monitoring means you have to every time flash it to get the data. And other is a real time when without doing anything, your mobile shows a continuously report coming from that. Luckily in India, we have all varieties of continuous glucose monitoring available.
Like Dexcom.
Dexcom is a continuous glucose monitoring.
Medtronic Guardian.
Medtronic Guardian. We have Libre, which is Abbott Libre Pro and Libre both. In the same way, Medtronic also we have a professional one as well as real time. So now these are the major companies in the world which are available. But in the world, there are multiple other companies and many of these companies are not available. Problem also in India, they are more costly. That's the reason patient has to pay from their pocket. They may not agree for that and they don't want to measure. But many times the patient and doctors, both of them, they don't agree to measure continuously. And that's the reason we have to educate the people. It's not always the cost which is a major challenge. I feel 30% of our Indian patients are very affording and they can afford. The problem is here the education and awareness, and the NUCD or any such organization which we are doing these type of different educational programs. Our primary idea is to educate our colleagues, our primary care physicians, our junior doctors or the practicing doctors in the villages. They should also know the newer and newer technology. And at the same time, it will also increase the awareness about using these newer technology. India is otherwise very techno savvy. We are the one who are highest user of, the phone, phone users, smartphone users in the world. We are highest. We are using highest number of time WhatsApp. We are using social media very high. So it means we are techno savvy. But the problem is we are not using these technology when it comes in health. So using technology in health will definitely improve the care for diabetic patient as well as other health problems.
Yes, some doctors have already started using electronic medical records. And when they are using CGMS, can that CGM data be integrated to any of the EMR, or
Yes.
what is your opinion?
So electronic medical records data, now recently the two companies to whom I am working with them, the way this is not right platform, but because for the audience, Eka Care and HealthFlix both allow that a continuous glucose monitoring data can be incorporated in the electronic medical record system. So which I am using, and it is very friendly electronic medical record system, and where you can easily incorporate the data of CGM inside your electronic medical record system.
How do you recommend CGM for pregnancy and GDM?
So I think the usage of CGM in GDM or a hyperglycemia in pregnancy is very, very high, because that is the condition where you need a very tight glycemic control. You need someone who is pregnant. The sugar should remain between 63 to 140 most of the time. More than 90% of the time, their sugar should remain in this tight control. And when you want to keep someone in a very tight control, and many of these patients, other than nutrition therapy, they are on insulin therapy, and the risk of hypo is also very high when they are on insulin therapy. So you want this very tight glycemic control, and to achieve this, the best option is to get them a continuous, right? By most of patients who are pregnant and having hyperglycemia in pregnancy, whether they are pre-gestational diabetes or acute gestational diabetes, I recommend them very strongly, and many of them are using, and we get successful outcome of the pregnancy also.
Being the leader of RSSDI, you have taken many positive steps to bring type 1 diabetics into one platform. But how can we provide those poorer diabetic children who are given free insulin, free glucometers and all those things? What is your thought that how can CGMs be introduced to the poor India?
So the one first very important question which you are saying, Alok, that how we can provide these newer technology to our patients who can't afford it. I will put it underprivileged children, these type 1 who can't afford it. So let us put, like in India at present, we have, as per the latest data of IDF, around 226,000 type 1 children, which is below the age of 20. I am not talking of adult type 1, which is another 5 to 6 lakhs. So as a doctor, as a diabetologist, as a community of diabetologists, whether from RSSDA, Diabetes India, whether you and me, if we all started using continuous glucose monitoring for our type 1 and type 2 who are in need, and those who can afford. So let us put, in India, we have 10 crore people with diabetic patients. Out of them, 5 crores are under the care of different people. Out of 500 crore, there are around 2 crore people who are relatively going to the physicians community, and a larger, who can afford also. And out of them, 20-30% of the patients are real afford. So like you can understand, out of this 2.5 crore, it means your 50 lakhs people or 5 million people are affording. Now, if we get these 5 million people a better device, a better monitoring system, a patient who can afford and they can buy and they can use it. So what will happen? This industry will also have a handsome amount of funding. And I'm sure if they will have a handsome amount of funding, they will put a lot of money for these poor children by providing them free. I give an example how CDIC started. You and me had given a lot of patients the non-notice insulin, and that's the reason they are providing today 4,000 children free of charge insulin. We started giving them first a vial, now today we are giving them pen, and probably by next year or 2 years, we will be giving them analog also. So the point is, industry is one side earning, and they want to give back to the society for providing free. Like you and me providing so many children free of charge consulting. Why we can do is because you are 80% of the patients, they are paying you, and that's the reason you can give back to the society these.
Banshi, do you have any idea whether our top science institute like Indian Institute of Science or IITs are planning any such device in a cheaper version?
Yes, so IIT is working on it, and maybe in India we may get within 1 or 2 years a device which will be not only insulin pump as well as continuous glucose monitoring, which will be made from it. And that may be definitely cheaper. But as I told you, as the number of users will increase, the cost of these devices in India will also be decreased because import will be high. More number of companies will be in India. Like the number of cars user in India, number of mobile users in India, and definitely cost decreases. So these devices cost will decrease always when we will be using it more and more.
Do you find any scope of this CGMS maybe periodically in pre-diabetics and obesity patients?
Yes. So during nutrition counseling, particularly for pre-diabetic patients, when we don't want to give them a medicine, we want to control them only by nutrition counseling. They definitely get the benefit of using continuous. Because a person who is having HbA1c of 6 point, I'm sure his occasional post-meal glucose is the condition that is leading them to 6.4 HbA1c. Their fasting will be always normal. So if we put them on this, it gives an educational and a motivational tool. Because while seeing your report, you will find, oh, my breakfast is increasing my sugar to 180. Let me change my breakfast and it will help me to decrease my 180 to 120. So, this becomes an educational as well as motivational tool. So I use it for many of my pre-diabetic patients to whom I don't want to give them a medication. Now, for non-diabetic or obese people, just to give them an idea that how different type of high carb or a simple carb diet can increase your sugar level. Even if it goes 140 because they are not diabetic. But it should not go more than 110 or 120. Why it should go if you are using a complex carb or if you are not using a simple carbohydrate? So just to educate them, sometimes we use it, but there is no data strongly. But definitely for pre-diabetic and for a nutrition counseling,
it can be used.
Really helpful, and it is really helping, and there are a lot of data outside.
Thank you, Banshi. This is a wonderful discussion. You are the best in the country to speak on CGMS and new things. And as you know, we are doing only blood glucose test in the laboratory. Then these glucometers came, and then now CGM is coming. And in 5 years or 10 years, this will be routine practice for our clinicians to treat diabetics with CGMS or any advanced instrument also. So our doctors should be aware that this is an equipment in their hand to give a better quality of life to their patients. Thank you, Banshi, and welcome to NUCD. Thank you.